Hi guys. So this will be a little bit new for you. I don't know if your other classes do this at all, but you can just click hopefully you guys have no problem finding this. And the slides are posted too for your reference. If you have any questions about the content or anything I talked about, obviously this isn't live, so you can definitely email me or ask me next week when hopefully I'll be back. Update, my wife's doing just fine. It's just kind of a pain. She's just shaken up and a little bit sore. She was rear-ended, so not her fault, and which is nice for insurance purposes. Although it is still a lot of like calling places and getting things done and getting car repaired and all that stuff. So anyway, we're doing good. But thank you for the nice emails some of you sent, so I do appreciate that. So anyway, we're going to talk about stroke today. Today's kind of going to be a neurologic potpourri thing. We're going to do 3 small lectures, so you guys can watch these at your convenience. And each one's probably going to be only about 15-20 minutes, so it should be a nice little break of a week. So stroke is a super common problem. It's something that has a wide variety of implications as far as the lasting impact it can have on a person and a family. It can really lead to very severe disability, if not death on its own. So I work at Abbott. Abbott's a pretty big stroke center. It's one of the biggest stroke centers in the country. So we see a ton of these. So I'm pretty familiar with this stuff in general, but we're going to go through it pretty quickly. There's not a ton to talk about because I don't think there's a lot of new stuff with stroke that we haven't touched on already, but we'll go through it and I'll talk about some of the acute treatments. We're going to do a little bit more with acute stroke during the emergency medicine lecture this summer, so I'll just very quickly touch on that. But I thought stroke is such a huge component of neurologic care, especially in the hospital setting, that you guys should be aware of some of the basics. All right, so a stroke, it's very similar to a myocardial infarction as far as usually there's some atherosclerotic disease and you get plaque buildup in the arteries, eventually bursting, causing a clot and a blocked artery. Now, sometimes strokes can present a little bit interesting because you might see initial substantial deficits, and then that's like if a clot is in a larger artery, and then if it breaks off or smaller chunks get off, you might see a return of normal symptoms briefly because there's some blood flow in that area, but that blood flow is pushing smaller clots into smaller areas. So what you might get is infarctions later downstream, like maybe in these little vessels here, which usually doesn't have as substantial damage. Obviously, if you're blocking a major part of the brain, that's going to cause more damage. But so sometimes you might even see very small clots form in these areas, and those are more what we associate with transischemic attacks versus a cerebrovascular accident, which is TIAs are a component of that. But when we're talking about acute stroke, we're usually talking about a larger portion of the brain being disrupted as far as blood flow goes. So hemorrhagic stroke is just a little bit different. Besides ischemic stroke and having sort of that atherosclerosis pathophysiology, what you can also get is just defects in the arteries themselves. So you might have things called aneurysms where you have sort of a bubbling out of the arterial wall. And you can have these, they're usually, I think they're genetic. Sometimes if a patient presents with a small brain bleed because of an aneurysm rupturing, they may do some imaging and see if they can find other aneurysms, and they can prophylactically try and fix some of those. There's some cool technology out there and how they do this. It's all pretty much related to interventional radiology, so if you go into that field, you'll get familiar with it. But some of the things they can do is coil these. And so what they'll do is they'll take like a metal coil, a really thin piece of wire, usually made out of platinum, and they'll actually just coil it in here. And what that does is it prevents a lot of high flow blood, high pressure blood flow from getting into the aneurysm itself, and it causes some stabilization of the hemodynamics in that area. So really it decreases the pressure overall because the blood can't flow through that coiled up piece of metal as well as it can if it was just an open aneurysm. There's another cool thing that they do, and there's probably several other things, but one of the ones I've seen done, it's called a pipeline. And a pipeline is, think of it like a half pipe, and what they're doing is they would slide it in here and put it so it would cover this part of the wall, and it would block off the aneurysm completely. Now the pipeline is mesh, so their blood can get through it, but over time the blood can't flow very quickly through it, and ultimately that mesh piece should revascularize so that the wall can rebuild itself, therefore cutting off the aneurysm altogether. Okay, so modifiable risk factors. Diabetes, I put a question mark next to this one. We think of diabetes as being a big risk, but actually there's some conflicting evidence out there on how well your diabetes is controlled and not necessarily correlating with better stroke outcomes, interestingly enough. But it's thought, based on common sense, that controlling diabetes would hopefully have some control with decreased stroke risk. Hypertension is a big one, so 32% reduction with control. Smoking, 50% risk reduction within 1 year of quitting. Baseline risk 5 years after quitting. So stopping smoking is huge. I've seen people come into our hospital who have a stroke, and they'll be meeting with the neurologist, and if they're a smoker, he'll ask them, so if I sent you home and I discharged you tonight, which you wouldn't, but hypothetically speaking, if you did, would you go have a cigarette? And you always see these people's faces, and they kind of have these internal struggle. They've been smoking for so long, but they know that they almost lost a major portion of their brain, and so it's tough. It's a tough choice for some of these patients, but it is a huge risk reduction. For women, oral contraceptives, pregnancy, and menopausal hormone replacement therapy all have risk. Pregnancy being the biggest one. The more hormone, the higher blood concentrations of certain hormones, the higher risk. And we're going to talk about that during women's health, so I'm not going to get into a ton of detail on the specifics, but you're looking at least a double risk, and smoking increases the risk 7 times. So if you're ever working with women who are 35 years or older, and they want oral contraceptives and they smoke, it's highly recommended you don't prescribe them because the risk of stroke is so high. Sometimes providers may use that to their advantage and say, well, you want to keep taking your oral contraceptives, you need to stop smoking. And so they might give them that ultimatum. AFib, 68% reduction in stroke with warfarin, or you could add other anticoagulants here, like the new anticoagulants. Dyslipidemia, with statin therapy, you're looking at a fairly substantial reduction. Coronary heart disease, obesity, obesity thought to be linked, but again, it's kind of like diabetes where there's not really a known risk reduction. And then physical inactivity is a modifiable risk factor as well. Primary prevention, you want to reduce or eliminate risk factors. So if you have a patient with AFib, that's probably where this is going to apply most as far as anticoagulation goes, and it's the CHADS 2 VASC score. So you get the points are broken down there. Basically, if you get more than 1 point, you're looking at considering oral anticoagulation. If you get 2 points, you're considering oral anticoagulation for sure. Stroke signs and symptoms, this is just a public education thing. I think there's a lot of information out there to educate the public on how to recognize stroke. Time is brain, so we want to make sure that the earlier you get to a stroke center that can treat you, the better the outcomes. All right, so during an acute stroke, while you might think it would be helpful, anticoagulation really not super helpful. So it's not like if somebody comes in with an acute stroke, we don't start them on like a heparin drip. At that point, it doesn't matter. The stroke's already blocking an artery, and you can't break up a clot with heparin. So what we do is use a thrombolytic agent. The most common one is Alteplase or TPA. There's a couple other ones on the market that I honestly don't care about because I don't think they're used very often. Tissue plasminogen activator is exactly how it sounds. You're activating plasminogen. I've got a diagram showing a nice cartoon of how it works here in a second. Within 4.5 hours of symptom onset is generally the window you're looking at. 3 hours is preferred. The 4.5 versus 3, we're going to go over that during emergency medicine a little bit. But basically, if you're looking at which window of time to go off of, usually there's some stricter guidelines. So if you have a patient who's maybe higher risk for a bleed, you might not want to do that 4.5. If you have somebody who's healthier, relatively speaking, the 4.5 symptom onset might be a better option. But usually we go by the 4.5 for a lot of cases. 3-month outcome shows decreased disability overall, which is great. And then there is a slight risk of intracerebral hemorrhage. So it's rarely seen, but it does happen. TPA is not a benign drug, and of course, if you give it, you're risking bleed risk, or increasing bleeding risk. So what can happen with a patient who is an ischemic stroke is they can have what's called a conversion to a hemorrhagic stroke. And that can happen with Plasminogen activator. If the vessels potentially are damaged or something like that, and you're giving this clot buster, the clot breaks, you could end up with some vascular damage there, but and possibly intracerebral hemorrhage at that point. However, big studies have looked at this and they've seen no increased risk of mortality overall. Even though there is an increased risk of ICH, giving TPA does not seem to increase mortality. TPA dosing is really important. I'm not going to test you on it, but if you work in emergency medicine at a stroke center, you definitely need to know it. And just looking at the specific mechanism, so we have TPA, which is going to bind to plasminogen. It's going to activate it. Plasmin is then going to dissolve fibrin, and that's kind of how our cascade is working that way. Ultimately, the clot is dissolving. There's been some pretty good evidence to show that giving TPA faster, once you make that decision to do it, you want to do it quickly. The longer the brain is without blood, of course, there's more potential for damage. So we really want to make sure that time is of the essence. So even though you have that 3 to 4.5 hour window, it's really important not to abuse it. If you get a patient in and they had symptoms onset 10 minutes ago and they're a great candidate, go for it. Usually with strokes, the big thing first before you give this is to send them to a CT scan to make sure they don't have a brain bleed and that the stroke isn't being caused by some sort of hemorrhagic source. If they can rule out the hemorrhagic source, then usually they give TPA, assuming there's no other exclusion criteria, which are listed on this slide. And you can see there's a whole bunch of them. The ones I care about the most, and the ones I think most people care about, are blood pressure. If it's really high, you don't give TPA. However, you can lower it. So if you give somebody antihypertensive medications acutely, and you can get it down below 185 over 110, then you can give TPA. You just have to keep it low too. You don't want to bottom the person out, because generally a bit higher of a blood pressure is good. So if you can ride that kind of 160, 170 systolic, that's great. But you don't want to go over 185. And then the other big one is, of course, anticoagulation. So our AFib patients are at high risk for stroke. Even on anticoagulation, we may see them coming in with a stroke. So if their INR is elevated, or if they're on a new oral anticoagulant, which we can't really measure levels on, but if they are on it, generally that's a contraindication. So post-stroke, for secondary prevention, once somebody's had a stroke, you want to look at modifiable risk factors. So basically, there's a couple things we look at: statin and antiplatelet therapy. Really, those are the two big ones. So statin's required. There is some evidence to say that if cholesterol is quite low to begin with, like if their LDL is like 70, which is possible in having a stroke, you generally don't need a statin. However, some neurologists may be more aggressive about that, so that might vary practice to practice. So it's not necessarily like aggressive treatment in MI where once somebody has a STEMI, they're automatically on high-dose statin therapy. In this case, you could debate whether or not to give somebody a statin if their cholesterol, usually the cutoff is under 100 if their LDL is under 100. With antiplatelet therapy, aspirin works just fine. Some of the evidence out there shows that maybe some of these newer agents are a little bit better. There's a product called Agrinox, which is a combination of very low-dose aspirin, 25 milligrams, and this medication called dipyrimidol. And that product inhibits the activity of adenosine deaminase and phosphodiesterase. Eventually, this is just it's a different mechanism of inhibiting platelet aggregation than aspirin itself. It's twice daily dose. It's not cheap. It's not terribly expensive, but some insurances may not pay for it. I don't see a ton of patients on Agrinox, to be honest. Clopidogrel or Plavix would be probably the much more common one. And usually somebody's on one or the other. You may see people on aspirin and Plavix at the same time. It's a bit questionable. We can go back quickly to the primary prevention for AFib patients. So if they have 1 point or more, you could consider oral anticoagulation or aspirin plus Plavix. So if there's low risk AFib, they might be on both. Of course, if they have another indication for aspirin, like if they have coronary artery disease or post-acute coronary syndrome or something like that, they would probably be on an aspirin, and that at that point they'd probably be on Plavix too, right? So at that point, it's not really something to consider. But generally speaking, one or the other for a stroke patient. And then there's also a product called cilostazol or Pletol, which also works with phosphodiesterase 3 and prevents platelet aggregation. And that one, kind of similar to the way Agrinox works. It's a very uncommon medication. And of course, if you have somebody who requires anticoagulation for AFib, or whether they have, chronic VTE, recurrent VTEs, so they're on chronic anticoagulation, that's okay, and that usually takes the place of sometimes of antiplatelet therapy. Usually what you'll see on patients is they might be on a low-dose aspirin plus their anticoagulation for stroke, and that's pretty common. So I get that question a lot. Why is this person on anticoagulation and antiplatelet? Well, it goes back to how clots form, and right, in really high flow areas, so the arteries of the brain, you're more likely to probably get platelet aggregation first, so it is important to prevent stroke to have an antiplatelet therapy on, even if they are anticoagulated. All right, so usually your first choice based on the evidence is Plavix or Agrinox, and the evidence, well, I say evidence, I mean it's very slightly favorable towards these two versus aspirin. It's not like a slam dunk case, but generally speaking, these are preferred. Remember, Plavix, even though it's kind of a newer medication, it is generic, so it's relatively inexpensive. So most people should be able to afford Plavix. If for some reason they can't, 81 milligrams of aspirin is fine. It's been proven effective. It's been used forever. It's quite affordable for patients as well. As far as Pletal or Cilostazol, the generic name, where that really plays in is there's been some studies looking at specific populations of Asian patients with various Asian ethnicity, and it's been shown to maybe be slightly more effective than some of our other ones, but that's very limited data, so I wouldn't necessarily take that to the bank. I'd probably still, if I was treating a person of Asian ethnicity post-stroke, I'd probably still go with Plavix based on the more broad applications in the literature. All right, so that's all I've got for stroke. A nice short lecture, and we'll pick up with migraine here in a second. So again, if you have any questions, ask them in class next, or you can email me.